Okay, so we need to finish 100 pages more at the minimum. So that will take around 5 hours. Even if I start now, I'll end by 3 o'clock. But genuinely, I don't see any other way that I can finish off everything. Instead of doing 100 pages, I do like some. I'll finish until. I'll absolutely finish radiology. Renal disorders. Disorders I'll finish. And after renal disorders, I'll most definitely finish until this thing. Spleen I'll do off. Splenism, pancreas also I'll do off. Grade cyst, insulinoma, yeah. All this I can finish, yeah. Differential diagnosis of rate mass. So this is one part. Then we have to finish entirety of renal, and after finishing entire renal, I'll have to do what is it? I have to do. I'm leaving esophageal cancer to the last. I don't even know if I'll do esophageal cancer and gastric cancer and stuff like that. But more than surgery right now, I want to be able to do orthopedics tomorrow. So today will be the last, and I think I'll just forego all general stomach and esophagus I'll do, and only focus on orthopedics tomorrow. So I have 2 hours and little bit more than maybe 3 hours. Maybe I'll sleep at around 1 o'clock, and I should be prepared to write the exam at I'll wake up at 6 or 7 maybe tomorrow. No need to wake up. I need to wake up earlier. 5 o'clock I'll wake up, and I'll just keep on studying orthopedics the entire time. So by today 1 o'clock I need to finish everything, and I think it's possible. Okay, and then we have Corosier law, which is if obstruction is due to stone in the common bile duct, gallbladder will not be palpable, because the stone in the bile duct would have to come from a cholestasis gallbladder. So gallbladder will be thickened and not distensible. So there is gallbladder will not be palpable if there is a stone in common bile duct. If obstruction is due to a malignancy in common bile duct, gallbladder will be palpable, because gallbladder will be normal, so it gets distended once the common bile duct is obstructed. Exceptions is double impacted stone, one in gallbladder and one in cystic duct, large stone in Hartmann's pouch, empyema if there is gallbladder with common bile duct, empyema if it's there, with if common bile duct, stone, and gallbladder, empyema, and common bile duct stone, double impacted stone, and large stone in Hartmann's pouch. Okay, so laparoscopic cholecystectomy is the gold standard method to remove the gallbladder. In supine position, general anesthesia, NG tube, Foley's catheter, you make 4 ports. 10 mm port in umbilicus, 10 cm past 10 cm telescope, 10 mm port in midline epigastrium working as a working channel, 2 5 mm ports in the mid clavicular line and anterior axillary line in the subcostal region. So complications can be bile duct injury, bile leak, cholangiitis, subphrenic abscess, injury into colon, duodenum, and mesentery. Those are the complications. You have bile duct injury, bile leak, cholangiitis, subphrenic abscess, and injury into colon, duodenum, and mesentery. Contraindications: you have end stage cirrhosis, portal hypertension, cholangitis, which is cholecystectomy done after control of cholangitis, if that is there, and common bile duct stone done after extraction by ARCP. If it is a common bile duct stone, if it is a portal hypertension, end-stage cirrhosis, and cholangitis, you cannot perform a cholecystectomy. So then you have single incision laparoscopic surgery, SILS, in cholecystectomy, which is minimally invasive surgery through a single umbilical entry port. So you do 2.5 centimeter vertical umbilical incision, 10 millimeter telescope, and 2 5 millimeter instruments can be passed. So there is no visible scar and faster recovery is there, and complication may be umbilical hernia. Then Murphy's sign is elicited in patients with acute cholecystitis, asking the patient to take in and hold a deep breath while palpating the right subcostal area. If pain occurs on inspiration, when inflamed gallbladder comes into contact with the examiner's hand, the Murphy's sign is positive. Sonographic Murphy's sign is eliciting same sign using sonographic transducer. Then we have spleen. You have surgical anatomy of the spleen. It is a wedge-shaped organ present in the left hypochondric region. Weighs about 150 grams. So it is 12 into 6 into 3 centimeter. And the ligaments of spleen, you have linorenal ligament, which encloses the splenic vein and pancreatic tail. Gastrosplenic ligament, which contains short gastric vessels. Then blood supply, you have splenic artery, which is branches of celiac artery. Splenic vein, which joins the superior mesenteric vein to form portal vein. Spleen functions, you have mechanical filtration, remove senescent erythrocyte, clears the pathogen inside RBC, malaria and Bartonella, and transfer iron into the plasma from degraded hemoglobin. Then immune functions, you have a synthesis of IgM, propyridine and tufidine, and pitting also may be seen, which is symbol of particulate incision in the RBC like Heinz body, Howell-Jones body, Piper-Amir, and these incision inclusions are seen in post-splenectomy patients but will stay absent in splenenculi even after splenectomy. Look, it's symbol of articulate inclusions. Then reservoir function will be there. It contains 2% of blood volume and 8% of RBC. Splenenculi is single or multiple accessory spleens. If this is there, then this thing also will not happen. Howell-Jones, Heinz body and Piper-Amir bodies also will not be seen. So sites is location in the hilum of spleen, tail of pancreas, splenic ligaments, mesocolon or greater omentum, left ovaries and left testis. So after splenectomy, they undergo hyperplasia. Splenenculi shows absence of RBC inclusion post splenectomy. All accessory spleens should be removed during splenectomy in order to prevent the recurrence of the disease for which splenectomy will be performed. Then you have splenic injury or ruptured spleen. Spleen rupture can be a result of trauma, atraumatic response. It may be due to infectious mononucleosis, pregnancy and infection. Spontaneous rupture can occur due to reflex spasm of the splenic vein. Causes may be RTA, blunt injury, left lower rib fracture, spontaneous rupture due to malaria. So type, it can be splenic subscapular hematoma, clean incised wound may be there, lacerated wound will be there, splenic hilar injury may be there, torrential hemorrhage will be there which leads to death, and splenic injury will be associated with injury to left lobe of liver, tail of pancreas, left kidney, left colon and left ribs. All of those splenic injury will affect left. Whatever is left, it will affect all of them. And torrential hemorrhage, of course, hilar injury, torrential hemorrhage and death. Lacerated wound may be there. Clean incised wound is treated with splenography. Splenic subscapular hematoma, that is type 1. Rotafic incision, blunt injury, lower lip fracture and spontaneous rupture due to malaria. Okay, so clinical features, you have elevated left hemidiaphragm. Left hemidiaphragm will be elevated. Left lobe atelectasis can be seen. Pleural effusion will be seen. You have balance sign, Kayer's sign and latent period of Bandit. You can also have splenosis. So balance sign is unilateral dullness of left flank without shifting, which is collected blood will get clotted. Kayer's sign is referred pain to the tip of left shoulder, irrigation of diaphragm due to blood clot. Latent period of Bandit is initial clot seals the bleeding, later one will dislodge it, leading to torrential bleeding. Splenosis is autotransplantation of spleen fragments within a peritoneal cavity following rupture. Then complications, you will have a blood loss, DIC, splenic artery pseudoaneurysm, sepsis and splenic arteriovenous fistula. Then investigations you can do fast, which is focused abdominal sonar for trauma. Hemoglobin percentage you have to check. Packed cell volume you can check. Plain X-ray will show obliteration of splenic shadow, obliteration of psoas shadow, elevation of left heavy diaphragm, and fracture of lower lips can be seen. Then CT scan you can do diagnostic peritoneal lavage. You'll find more than 10 ml of blood, more than 100,000 WBC per millimeter cube, and more than 500 WBC per millimeter cube. Moving on, we have treatment. Treatment is initial management, which is ABC and central venous line, fluid and crystalloid therapy, and blood transfusion. Non-operative measures, you have angiographic selective embolization, isolated splenic injury if there is no associated injury. In hemodynamically stable patient, you can do an angiographic selective embolization. Then surgical management, you have splenectomy, which is having a complication of its own, OPSI, disseminated intravascular examination, coagulation, and left-sided atelectasis, pleural effusion, and pancreatitis. Splenography in cases of clean incised wound, suturing of wound with placement of gel foam and thrombin. Observable mesh is wrapped around the wound, and its advantages are that it avoids OSP, which is overwhelming post-splenectomy infection, and it avoids dead space in the abdomen. Then splenomegaly caused by TB infection, mononucleosis, malaria, typhoid, Kala Azar, blood diseases, CML, hereditary spherositis, ITP, metabolic Gaucher's disease, amyloidosis, porphyria, portal hypertension, malignancy, you'll see splenic carcinoma. So clinical features, you'll find mass in the left hypochondrium. It moves with respiration. You can also do hook sign, which is inability to hook under the left costal margin. Mass will be directed towards the right iliac fossa. Differentially, it can be a kidney mass, it can be a retroperitoneal left coronal mass, left arterial mass also it can be there. Splenectomy is indicated in splenic trauma, neoplasms, CML, primary splenic tumor, and as a part of other surgery like gastrectomy, pancreatectomy. So hematologically, you have intracellular defect, G6PD, hereditary spherositis, thalassemia, sickle cell anemia. Extracellular defects, you have autoimmune hemolytic anemia, ITP, TTP, idiopathic and thrombotic thrombocytopenic purpura. Symptomatic hypersplenism also you may be requiring to remove it. Myelofibrosis and other causes like Gaucher's disease, Pelti's syndrome, which is right atrium, rheumatoid arthritis plus leukoplakia plus splenomegaly, and schistosomiasis also you may have required to remove it. So complication immediate, you will have hemorrhage from the short gastric vessels, gastric dilatation will be there, hematemesis will be there, which is gastric mucosal congestion after short gastric vein ligation. So immediately you can do intermediate, you have left basal atelectasis, left pleural effusion, pancreatitis, pancreatic fistula, and left phrenic abscess. Delayed, you have thromboembolic episodes due to thrombocytosis after splenectomy, portal vein thrombosis, and OPSI. Then OPSI is overwhelming post-splenectomy infection, which is reduction of IgM, propyridine, and tiftin, and it is a defective phagocytosis of encapsulated bacteria by infection by Streptococcus pneumoniae, Haemophilus influenzae B, meningitis, group A Streptococci, malaria, and Babesia. All of them will occur. There is reduction of IgM, propyridine, 215, which is defective phagocytosis will be defective. Then clinical features, you will have fever, chill, sore throat, hypotension, shock, DIC, respiratory distress, coma, and death. Prevention, you provide vaccination of all the organism and anti-malarial prophylaxis. Treatment, you give antibiotics, which is third generation cephalosporin, and ventilatory support you have to provide. Then hypersplenism is overactivity of spleen resulting in pancytopenia and hypercellular bone marrow, and caused by primary hypersplenism, portal hypertension, infection, malaria, TB, Kala Azar, and myeloproliferative disorders. All of them can be the causes: portal hypertension, primary hypersplenism, portal hypertension, infection, malaria, TB, Kala Azar, myeloproliferative disorders. Okay. Then clinical features, you'll have transfusion dependent anemia, recurrent infection may be seen, spontaneous bleeding episodes can be seen, epistaxis and bleeding gums is noticed. Then investigation, you have peripheral blood smear you can do, bone marrow aspiration you can do, liver function test, and ultrasound abdomen can be done. Then treatment, you have splenic artery embolization and splenectomy. You can do artery embolization and splenectomy. Splenic artery embolization, splenectomy, removal of the spleen. Okay. Then pancreas. Finally, only 100 pages left. Then acute pancreatitis, it is due to get smashed. It is gallstones, ethanol, trauma, steroids, mumps, autoimmune, SLA, PAN, scorpion sting, hyperlipidemia, hypercalcemia, ERCP, drugs valproate, azathioprine, thiazide diuretics, and trauma. Infection. Get smashed. I get smashed. Infections is important, and valproate. I get smashed. Genuinely, I might just forget this. So pathogenesis, it can be due to pancreatic injury, release of inflammatory mediators like TNF alpha. This further stimulates release of cytokinin, interleukin 2, 6, 8, 10, bradykinin, periodic acid shift, leading to SARS and MODS. What is it? Systemic inflammatory response and syndrome and MODS, multiple organ dysfunction. Okay. Nausea will be there, vomiting will be there, hiccup will be there, belching will be there, oliguria will be there, and Mohammed prayer sign will be there. Sudden abdominal pain, it is relieved partially on leaning forward. Signs, you will have tachypnea, hypotension, tachycardia, flushing, facial flushing will be there. Grey Turner sign will be there, which is hemorrhagic pigmentation around the flanks. Cullen signs can be there, which is pigmentation around umbilicals, and Fox sign will be there, which is inguinal ecchymosis. Complications, you have pancreatic necrosis, wall of necrosis can be seen. So fat necrosis will be there, acute fluid collection and sequestration will be there, pancreatic pseudocyst formation will occur, acute tubular necrosis may be there, disseminated intravascular coagulation will occur, respiratory failure, acute respiratory distress syndrome, hematemesis or melena due to duodenal necrosis, and abdominal compartment syndrome can be happening. Splenic vein thrombosis also may occur. Then investigations, you have serum amylase, which is a threefold increase will be there. Serum lipase is the most sensitive, and serum trypsin can also be investigated. Blood glucose, you have hyperglycemia, calcium, serum calcium, you have hypocalcemia. The calcium is utilized during saponification of the fat around the pancreas. Then you have ultrasound abdomen, spiral CT, chest X-ray, which shows pleural effusion and acute respiratory distress syndrome, and you can do abdominal pain X-ray. You can find colon cutoff sign, which is transverse colon distension, and descending colon will be collapsed. Renal halo will be there, obliteration of source shadow will be there, localized ground glass appearance will also be there. Then management of acute pancreatitis, admission into ICU, analgesics you provide, which is what do you say, metamizole, buprenorphine. Analgesic you just provide. Fluid therapy, ringer lactate can be provided. Supplement oxygen, acute respiratory distress syndrome. They monitor the urine output and blood gas analysis, monitoring RFT, LFT, coagulation profile, serum calcium, and blood glucose. Serum calcium is most sensitive, I think. Serum calcium or coagulation, which is most sensitive? Yeah, serum lipase. Sorry. No. Serum lipase is most sensitive. Amylase also will be having threefold improve, and the serum trypsin also will be increased. Hyperglycemia, hypocalcemia, ultrasound abdomen, CT, MRI. Okay. Then antibiotics you can provide in case of cholangitis. Enteral feeding for nutrition can be done. Also on pancreatitis, you do ERCP within 72 or with common bile duct stenting. Then laparotomy and neurothectomy can be done. Remove some nerves, and continuous closed peritoneal lavage can be done. Then you have Ranson criteria in acute pancreatitis and its significance. So you have criteria in gallstone pancreatitis with score more than 3, which suggests acute pancreatitis, and you have criteria in non-gallstone pancreatitis. So on admission, if the age is more than 70 years, blood sugar is more than 220 mg percentage, LDH is more than 400 international units per liter, AST is more than 250 international units per 100 ml. Within 24 hours, you can notice hematocrit low more than 10%, blood urea nitrogen more than 2 mg percentage, serum calcium less than 8 mg percentage, and fluid sequestration more than 4 liters. If all of this occurs, then it is if it is occurring, and if score is more than 3, it suggests severe acute pancreatitis. And in non-gallstone, on age more than 55 years old, blood sugar more than 200 mg percentage, LDH more than 350, AST more than 250, hematocrit drop more than 10%, blood urea nitrogen more than 5 mg, serum calcium less than 8 mg, and fluid sequestration more than 6 liters. Basically you need to much remember you remember. Okay. Then chronic pancreatitis, etiologically it can be due to alcohol. Tropical pancreatitis may be there, obstructive pancreatitis may be there, autoimmune pancreatitis, hyperlipidemia, hyperparathyroidism, trauma, and cystic fibrosis. All of them will cause chronic pancreatitis. Of this, cystic fibrosis, hyperparathyroidism, hyperlipidemia, autoimmune, obstructive, tropical. Okay, these three are a little bit more important. Okay, as you'll forget it more. And pathogenesis, oxidative stress hypothesis, toxic metabolite theory, and stone and duct obstruction theory. So oxidative stress, chronic reflux of bile with reactive product of hepatic function will lead to pancreas will be damaged. Toxic metabolite theory, alcohol will directly damage the pancreatic acinar cell, leading to fatty degeneration and necrosis. Stone and duct obstruction theory, alcohol increases lithogenicity of pancreatic juice, leading to stone formation and duct obstruction. Oxidative stress theory, toxic metabolite theory, and stone and duct obstruction theory. So the spectrum of chronic pancreatitis, early, moderate, and late. Early is inflammation and pancreatic edema, early fibrosis, exocrine dysfunction, and severe fibrosis and loss of secretory function. So inflammation and pancreatic edema, early fibrosis, exocrinal dysfunction, severe fibrosis, loss of secretory function, diabetes mellitus. That is the spectrum of chronic pancreatitis. Pathogenesis, of course, oxidative stress, toxic metabolite theory, and stone and duct obstruction theory. Stone and duct obstruction theory, toxic metabolite theory, and stone this thing. What do you say? Oxidative stress theory. So alcohol will influence two of them, whereas the first one is due to reactive protein of hepatic function. Alcohol. Then clinical features, you have abdominal pain, exocrine dysfunction will be there, diarrhea, malabsorption, steatorrhea, endocrine disruption, you have brittle diabetes, which is insulin deficiency leading to diabetes mellitus. You will have glucagon deficiency. Glucagon deficiency will be there, insulin deficiency will be there, which will lead to diabetes mellitus, which is brittle diabetes. Then exocrine dysfunction and diarrhea, malabsorption, steatorrhea, abdominal pain will be there, mass per abdomen, tender just above the umbilicus. Then you have Mallet-Guy's sign, which is right knee to chest position. Palpation of left hypochondrium will show tenderness. Then classical triad, because this thing pancreas will be pushed to the left, and when you palpate it, you touch it. Classical triad of chronic pancreatitis, you have pancreatic calcification, steatorrhea, and diabetes mellitus. Complications, you will have pancreatic pseudocyst, pancreatic ascites, fistula, carcinoma of the pancreas, and portal vein thrombosis. Differentially, it could be a carcinoma head of the pancreas or retroperitoneal tumor. Investigations, blood test, blood glucose you can do, LFT you can do, stool examination you can do, fecal elastase will be less than 200 microgram per day. Steatorrhea will be there more than 7 gram per day. Secretin cholecystine cystokinin test, which assess the pancreatic function. Pancreatic oral test, which can be done. ERCP is chain of lake appearance will be seen. CT, abdomen, pseudocyst, calcification, duct stones can be seen, and endosonography, malignancy, and duct stasis and CVD can be seen. So in this investigation also you can find, no, you don't find lake of, what is it? Pool of lake, what is it? Chain of lake. There's no chain of lake in this one. Only hyperglycemia, spiral CT you can do, MRI, abdomen, chest X-ray, colon cutoff sign is there, renal halo is there, obliteration of the psoas cytos is there, localized ground glass appearance is there. There's another thing which has chain of lake appearance, I thought. Okay. Endosonography. Okay, fine. Treatment. You have conservative treatment, which is to avoid alcohol, low fat diet, analgesics, pancreatic enzyme replacement therapy, and control of diabetes using insulin. Surgeries can be indicated in severe malabsorption, suspicion of malignant transformation, biliary obstruction like Wadsworth syndrome, pancreatic pseudocyst, and pancreatic ductal dilatation. If it is more than 7 cm. Drainage procedure, you have modified Pustow procedure. And resection and drainage procedure, you have Whipple's procedure and duodenal preserving pancreatic head resection, DPPHR. You have Burgess syndrome, Fraser syndrome, and Burns procedure, and you have total pancreatotomy. So treatment is, of course, avoid alcohol, low fat diet, analgesics, pancreatic enzyme replacement therapy, control diabetes using insulin, severe malabsorption, suspicion of malignant cancer, Wordsworth syndrome, pancreatic pseudocyst, pancreatic ductal dilation more than 7 cm. Then drainage procedure, modified Paisto procedure. Resection and drainage is Whipple's procedure, duodenum preserving pancreatic head transection, total pancreatectomy. Then pancreatic functional tests, you have serum amylase, creatinine clearance ratio, serum lipase, which is more specific than amylase, serum lactinase, serum trypsinogen activation peptide, TAP assay, phospholipase A2, blood glucose, serum calcium, and LDH levels. All of these you can perform. Amylase creatinine clearance ratio, serum lipase, lecithinase, trypsin antigen, phospholipase, blood glucose, serum calcium, LDH level. All of them are pancreatic function tests. Biliary obstruction is also called Wordsworth syndrome. Modified Paisto procedure. Whipple's procedure is commonly done for chronic pancreatitis. Give me a second. I need to read up on Whipple's procedure. Okay, then moving on. Pancreatic pseudocyst. Pancreatic pseudocyst is a localized collection of sequestered pancreatic fluid, occurs 3 weeks after an attack of acute pancreatitis. Initially, cyst wall is thin, uniform, unformed, and later it gets fibrosed and thickened. So site will be in the lesser sac. Type will be communicating pseudocyst, non-communicating pseudocyst. So you will be having epigastric swelling, does not move with respiration, pulsation confirmed by knee to chest position. Bait test, which is pseudocyst pushes stomach in the front. Rice tube it will be filled per abdominal, because the pseudocyst will push the stomach front. It can also be aneurysm, pseudo-retention cyst, cholangio, carcinoma of the pancreas, etc. Complications, you have rupture, infection, duodenal obstruction, portal in thrombosis, and common bile duct blockage, which is cholestasis. Cholestasis will be there, rupture will be there, infection will be there, duodenal obstruction will be there, portal vein thrombosis will be there. So investigations, you have ultrasound abdomen, size and thickness of a pseudocyst you have to observe. CT scan, you can see the size, number, cell wall thickness of pseudocyst. ERCP to visualize the communication. Endoscopic guided aspiration analysis of fluid, you will find increased amylase and normal CEA. Increase in CEA indicates mucinous neoplasm. Neoplasm indicates. So treatment is surgical drainage if it is more than 6 infected pseudocyst, multiple cysts and communicating cyst. If it is there, then you do surgical drainage. Cystogastrotomy, which is Duras operation, you can do. Cystoduodenostomy or cystogenostomy, which is the best option. Cystogenostomy is the best. You remove the cyst via jejunum. Duras operation also can be done. Okay. Then reverse 3 sign, which is Frostberg's inverted 3 sign, seen in barium sedis of upper GI tract. Cancer. I think cancer. Broadening of duodenal loop. Duodenal loop will be broadened with a puckering around the ampulla of the ureter. Then you have insulinoma, which is endocrine pancreatic tumor arising from B islets of pancreas. Clinical features, you have abdominal discomfort, trembling will be there, sweating will be there, hunger, dizziness, diplopia, hallucination, epilepsy, weight gain will be there due to overeating, and Whipple's triad, which is hypoglycemia attack in fasting state, blood glucose less than 14 gram mg percentage, and symptoms relieved by administering glucose. This is endocrine pancreatic tumor arising from B islets of pancreas. Okay. So clinical features: abdominal discomfort, trembling, sweating, hunger, dizziness, diplopia, hallucination, epilepsy, weight gain due to overeating, Whipple's triad, hypoglycemic attack in fasting state, blood glucose less than 14 mg/%, symptoms relieved by administering glucose. It can also be okay, no need for differential diagnosis. Investigations, you can do insulin radio assay, insulin level very much increased, glucose insulin ratio is also very much it's more than 0.3, proinsulin level more than insulin level, elevated C peptide level will be there, blood glucose will be less than 40 mg%. Then you can do insulin provocation test using calcium gluconate and tolbutamine. MRI will localize the tumor and CCT will localize hypervascular lesions. Endoscopic ultrasound also can be done. You can do abdominal discomfort will be there, trembling, sweating, hunger, dizziness, diplopia, hallucination, epilepsy, weight gain due to overeating, Whipple's triad, which is hypoglycemic attack in fasting state, blood glucose very much less, symptoms relieved by administering somatostatin receptor scintigraphy localize the site of tumor. Gastrin provocation test using calcium you can provide calcium. Secretin provocation test can be done. MRI and CT scan can be done. Treatment, you can do enucleation of the tumor, distal pancreatectomy, subtotal pancreatectomy and pancreaticoduodenectomy. You can remove part of pancreas. You can do pancreas to duodenum. Distal pancreatectomy also you can do. Enucleation of the tumor can be done. Fasting gastrin more than 1000 picogram per ml. Somatostatin receptor scintigraphy locate the site of tumor. Gastrin provocation test, calcium you provide. Secretin provocation test, MRI and CT. Hypersecretion of gastric acid, severe peptic refractory ulceration, bleeding and perforation of ulcer. Enucleation of treatment is enucleation, pancreatitis, duodenectomy. Solution, Ellison syndrome. These are hyperplasia and gastrocnemias. Then you have pancreatic divisum, which is failure of fusion of ventral and dorsal pancreatic duct leads to drainage of dorsal pancreas through the duct of Centroni, which is minor papilla. Drainage of ventral pancreas through the duct of Wirsung, which is major papilla. Causes major pancreatic secretion drain into the minor papilla, leading partial obstruction, leading precipitating pancreatitis. Okay, then I'm going to skip retroperitoneal tumor due to radiation, chemo. All these tissues, the tumor will be arising from mass per abdomen, pelvic mass, abdominal mass, anorexia, CT, everything. Treatment is complete in block excision, limited dissection, debulking, and post-operative chemotherapy and radiotherapy, depending upon the size, grade, distance, and dissectability. Differential diagnosis of mass per abdomen: right hypochondrium, palpable liver, and palpable gallbladder. It moves with respiration, dull note. Fingers can be insinuated. Soft, non-tender is some stuff. Soft tender is amoebic. Hard mass is hepatoma, solitary lesions. Hard multinodule is multiple secondaries and micronodular cirrhosis. Gallbladder moves with respiration, dull and below the right costal margin. Condition: soft non-tender is mucosal, enlarged gallbladder in CVD obstruction due to pancreatic head or this thing, periampullary cancer. Tender will be empyema. Hard is carcinoma. Other masses you have apopole kidney mass and pericholestatic inflammatory mass. Mass in epigastrium, palpable left lobe of the liver, moves with respiration, dull. Hepatoma, amoebic liver abscess, hydatid cyst, and left lobe secondary. Epigastric stomach mass may be there, moves with respiration, resonant. Esophageal dysphagia of the carcinoma stomach, leiomyoma stomach. Pseudocyst of the pancreas does not move. Transmitted pulsatile, elicited in nearby position, resonant braid test. Stomach is full, laced can be filled. Adenocarcinoma of pancreas does not move. Resonant. Compliance of back pain due to compression of lumbar nerve. Carcinoma of transverse columns does not move. Cecum will be dilated and palpable, resonant on percussion. Para-aortic lymph node mass does not move. Mass may be due to TB, secondary lymphoma, aortic aneurysm, soft pulsatile. Okay, you can write on your own. Left hypochondrium and last spleen, left-sided colonic mass, left kidney upper pole, left adrenal mass, left rising from tail of pancreas, mass in lumbar region. Palpable kidney mass, ascending colon mass. It moves with respiration, bimanual. Renal angle dull, does not cross the midline. Hydronephrosis, pyelonephritis, polycystic kidney, renal cell carcinoma. Descending colon mass are on the right side, descending colon mass are on the left side. It is seen in lumbar region. History of altered bowel habits, does not move. Renal angle resonant, and proximal dilated bowel may be palpable. Proximal dilated bowel may be palpable. Mass in umbilical region, mesenteric cyst, Tilak's triad, which is internal abdominal umbilical mass, resonant on percussion, intestinal obstruction, volvulus will be formed. That is Tilak's triad. Then omental cyst also can be there, which moves with respiration, dull. Small bowel swelling, small bowel neoplasm, intersusception. Does not move with respiration, contacts under palpating finger. Red currant jelly stool. Red currant jelly stools is important. Then mass in right ilia fossa, appendicular mass will be there, appendicular abscess. Tender mass resonant, does not move. Well localized mass. Tender mass, dull, indistinct borders. Carcinoma of the cecum, hard nodular mass, does not move, resonant, and intestinal obstruction. Ileocecal TB, non-tender, does not move. Cecum protein number. Amoeboma may be there. Tender mass, well defined with distinct border. History of dysentery, psoas abscess, psoas spasm, and spine shows lupus. Tenderness, reflection of fibrin will be paraspinal spasm. Mass in the left iliac fossa, carcinoid sigmoid colon. Ovarian mass, psoas abscess, ectopic kidney, and undescended testis, and lymph node. Left iliac fossa, sigmoid colon mass, ovarian mass, psoas abscess, ectopic kidney. Mass in hypogastrium, epigastrium, hypogastrium. Okay. Bladder mass will be there, dull on percussion, mass indices of time being fell per rectum examination, uterine mass per vaginal examination, ovarian mass, left abdominal mass per rectally or per vaginally, and abdominal wall and umbilicus I am not going to study. Jasmin's tumor is an important thing. Recurrent fibroma of Peyer's. 1 second. Tumor arising from musculoaponeurotic layer of abdomen below the level of umbilicus, encapsulated hard aggressive fibromatosis, and etiology 80% female, old abdominal scar, oral contraceptive use, familial polyposis colon, osteoma, Gardner syndrome. Clinical features: you will have slow growth, no metastasis, no sarcomatous change, and is seen below the umbilicus. Investigations: you do barium enema, X-ray, ultrasound abdomen, MRI, biopsy. You will find multinucleated plasmatal giant cell. Treatment is wide excision of the tumor with placement of mesh and chemotherapy. This is the only thing which is important, which is tumor arising from mucoaponeurotic layer of abdomen below the level of umbilicus, encapsulated hard aggressive fibromatosis, 80% female, old abdominal scar, familial polyposis, Gardner syndrome. Slow growth, no metastasis, no sarcomatous change, seen below the umbilicus. Barium enema you can do, X-ray, MRI, giant cell, biopsy, multilateral giant cell, so it's called Peyer's. That's why it's called Peyer's. Okay. Chemotherapy, wide excision. Okay. Umbilical edema, no need. Example mass is failure of all or a part of the gut to return to coelomic cavity during early fetal life. There is a sac containing the content. It is very thin and consists of outer amniotic membrane, middle Wharton's cilia, and inner peritoneal layer. So failure of all or a part of the gut to return into coelomic cavity during early fetal life. Outer amniotic membrane, middle Wharton's duct, Wharton's cilia, and inner peritoneal layer. Omphalocele is associated with congenital cardiac anomaly, genital anomaly, and Beckwith-Wheater syndrome. Exophthalmos, macroglossia, gigantism. Beckwith-Wiedemann syndrome. Treatment types: you have examples minus and examples major. Examples minus is small sac, defect less than 5 cm, content is only small bone, and primary closure is possible. An example measure is large sac defect more than 5 centimeter. Content is liver, small and large bowel, and primary closure is not possible. Management, you have vitamin K injection can be given, total parental nutrition, sepsis control with antibiotics, evaluation of other anomalies. You have a prevention of hypothermia. You wrap the content with sterile bag, and correction of dehydration, and surgical procedure is there, which is release, incision and closure. You have to release the incision and you have to close. Then we move on to hernia, which is etiologically due to straining, lifting heavy weight, chronic cough, TB, chronic bronchitis, asthma, emphysema, chronic constipation, urinary cast, benign prostatic hyperplasia, stricture, urethra and phimosis. You can also have obesity, pregnancy and pelvic anatomy, especially femoral hernia in females. It can be due to smoking, ascites, appendectomy, due to through the McBurney incision, ilioinguinal nerve injury, right side direct inguinal hernia. Indirect inguinal hernia remnants of process vaginalis. That's why it's in indirect inguinal hernia. Familial collagen disorder like prune belly syndrome and collagen deficiency state like metastatic emphysema of Reed. These are all somewhat rare things. This is common: straining, lifting heavy weight, chronic cough, constipation, urinary cough, BPH, stricture, urethra, phimosis, obesity, pelvic and pathology, smoking, ascites. Smoking decreases the wall compliance. Ascites, it'll just increase the pressure. Appendectomy through the McBurney incision leading to ilioinguinal nerve injury. This is rare. Indirect inguinal hernia, remnants of process vaginalis, you have to remember. Familial collagen prune belly syndrome, metastatic emphysema of Reed. All these 4 things you have to remember. Parts of hernia, you have sac. Okay. What is this? Yeah. It is 7. Mouth, neck, which is narrow in indirect hernia, wide in direct hernia. Body and fundus. Mouth, neck, body, fundus. Hernia without neck, hernia with large mouth sac, example direct hernia, incisional hernia, hernia with a sac, epigastric hernia. Retribution of extraperitoneal fat. Okay. Sac is the diverticula of the peritoneum, consists of mouth, neck, body, fundus. Okay. Coverings of the sac may be layers of the abdomen, you have to remember. Contents will be omentum, is omentocele, intestine, enterocele. Reaches hernia is a portion of bowel wall. Urinary bladder is cystocele. Ovary is often with fallopian tube. Litus hernia is Meckel's diverticulum. Appendix is Ameland's hernia. So classification of hernia: clinical, you have reducible hernia and irreducible hernia. Reducible hernia gets reduced on its own or by patient or surgeon. Exponential impulse on coughing will be present. Then irreducible hernia, contents of hernia cannot be returned to the abdomen due to narrow neck, adhesions or more content inside the sac. Obstructed hernia is irreversible hernia with obstruction. Blood supply to the content is not interfered, however, eventually it leads to strangulation. Inflamed hernia, inflammation of the contents, appendicitis, salpingitis, overlying skin is edematous. You will have strangulated hernia, which is irreversible hernia with obstruction of blood flow. Tense, tender swelling, no impulse on coughing, commonly seen in indirect inguinal hernia and femoral hernia. We have occult hernia, which is hernial swelling is clinically not detectable, but presents with growing pain, may not be expansile on impulse of coughing. Classification based on sites, you have lumbar, obturator, umbilical, inguinal and salpingian. So lumbar obturator via obturator foramen, Handlington cave sign, which is obturator nerve compression leading to absent obturator reflex. Umbilical, inguinal, spleen, femoral, epigastric, ephrematics, sliding, sportsman, albino due to attraction. None of these are important. Inguinal hernia, surgical anatomy, superficial inguinal, deep inguinal, 1.2 cm above the pubic tubercle, triangular opening in external oblique aponeurosis. Deep inguinal ring or internal ring is U-shaped condensation of transversalis fascia, lies 1.25 cm above mid-inguinal point, halfway between anterior superior iliac spine and pubic symphysis. Inguinal canal is 4 cm long, situated above medial half of the inguinal ligament. In female, it is called as canal of Nick. Contents: you have ilioinguinal nerve, iliohypogastric nerve, spermatic cord in male, and round ligament in female. Ilioinguinal nerve, iliohypogastric nerve, spermatic cord in male, round ligament in female. Contents of spermatic cord, you have vast difference. arteries like testicular and cremasteric and artery to the vas. Veins, you have pampiniform plexus of the veins. Lymphatics of testis also will be there. Sympathetic plexus around the vas deferens is the genital branch of genitofemoral nerve, remnants of tarsus vaginis. All of these are present in spermatic cord. Defense mechanism of inguinal hernia, you have obliquity of inguinal canal, arching of conjunctival, shutter mechanism of internal oblique, ball valve mechanism, cremasteric muscle contraction plugs the superficial ring, and slit valve mechanism, external oblique muscle contracts the intracranial fibers of superficial ring. So classification, you have anatomical classification, which is direct hernia and indirect hernia. Direct occurs through posterior wall of inguinal canal like Hasselbalch's triangle, medial to inferior epigastric artery. Indirect hernia occurs through the internal ring, lateral to the inferior epigastric artery. Classification is based on the extent. You have incomplete and complete. Incomplete, you have bumonocele and funicular. Bumonocele is sac confined to the inguinal canal, and funicular is sac crosses the external ring, does not reach the bottom of scrotum. Then complete is sac descends completely to the bottom of scrotum. So here it is confined to inguinal canal, crosses the inguinal external ring, does not reach the bottom of scrotum. Here it descends to the bottom of scrotum. Anatomically, you have a direct hernia, indirect hernia. Direct through posterior wall of the inguinal canal, Hasselbalch's triangle, medial to the inferior epigastric artery. Indirect hernia occurs through internal ring, lateral to the inferior epigastric artery. Indirect inguinal hernia is more common in younger age group. 65% of all inguinal hernia are indirect. It can be incomplete, bumonocele, funicular, or complete scrotal. Direct inguinal hernia, 35% of all inguinal hernias are direct, more common in elder age group, occurs through Hasselbalch's triangle, which is a weak spot in anterior abdomen through which direct hernia occurs. Medial and lateral border of the rectus abdominis is there. Lateral border, inferior epigastric vessel will be there. Below will be medial part of inguinal ligament. Floor will be fascia transversalis. Floor is fascia transversalis. Below you have medial part of inguinal ligament. Laterally you have inferior epigastric vein. Okay, now. Give me some time. Agnya, if I do, it's very much enough. Then I can move all the way to kidneys. Rectum I want to do, appendix I need to do. But kidneys is the main, man. I don't know how long it will take for me to finish this, man. It's taking too much time. So appendix is important. Honestly, that's too much to teach you. I'll just study on my own and feel. I'll stop this now. Yeah.